The nursing student cares for a patient newly diagnosed with inflammatory bowel disease, IBD. He decides to review the different types of IBD, ulcerative colitis and Crohn's disease. Which of the following statements is not true about these types of IBD? A. Ulcerative colitis usually manifests with fatty stool, steatorrhea. B. Complications of Crohn's disease include fistula formation and intestinal obstruction. C. Ulcerative colitis and Crohn's disease may occur in very young children. D. Complications of ulcerative colitis include hemorrhage, abscess formation, and arthritis. E. Crohn's disease presents with weight loss, anemia, and dehydration. The answer is C. Ulcerative colitis and Crohn's disease may occur in very young children. Ulcerative colitis has a usual age of onset from 20 to 30 and 50 to 80 years old. Patients with UC have frequent fatty stools with occasional rectal bleeding and abdominal pain after eating. Nurses who care for patients with UC must consider possible intestinal obstruction and fistula formation in these patients. Crohn's disease has a usual age of onset from young adults to middle-aged, 30 to 50 years old. Patients with Crohn's disease did not have fatty stools but do have common rectal bleeding that may lead to hemorrhage. These patients experience pain before defecating and will have 10 to 20 liquid, usually bloody, stools per day. Nurses who care for patients with Crohn's disease should consider possible abscess formation and arthritis. Both UC and Crohn's disease present with weight loss, anemia, and dehydration due to ineffective nutritional absorption through the intestinal tract. Nurse is discussing with a 56-year-old male client causative factors that have led to his development of peptic ulcer disease. The nurse realizes that there is need for further teaching when the patient makes which of the incorrect statements? A. I will eat several small bland meals daily, and avoid irritating foods such as raw fruits and vegetables. B. I will take my prescribed triple therapy with antibiotics and proton pump inhibitor to eliminate the H. pylori infection for 2 months as instructed by my physician. C. I will quit smoking, as I understand nicotine contributes to the development of gastric ulcers. D. I am aware that I should engage in relaxation techniques to minimize stress, to help reduce the acid my stomach produces. E. I will avoid certain medications such as aspirin, NSAIDs, and corticosteroids. They are capable of disrupting the stomach lining. The answer is B. I will take my prescribed triple therapy with antibiotics and proton pump inhibitor to eliminate the H. pylori infection for 2 months as instructed by my physician. The treatment for peptic ulcer disease when the bacterium H. pylori is found to be present has several treatment strategies. These strategies include a triple drug therapy consisting of a proton pump inhibitor, amoxicillin and clarithromycin. This combination of drugs should be continued for 7 to 14 days, 2 months is not the course of treatment. All other statements are consistent with proper teaching of causative factors associated with peptic ulcer disease. A nurse is retrieving a report from a hepatic biopsy in a patient with an acute hepatitis B infection. The report describes swollen hepatocytes with irregularly clumped cytoplasmic organelles and large clear spaces. This is known as which of the following? A. Ascites. B. Ballooning degeneration. C. Fibrotic changes. D. Necrosis. The answer is B. Ballooning degeneration. Ballooning degeneration is a form of hepatocellular apoptosis, rather than necrosis, in which hepatocytes swell and begin to show irregularly clumped cytoplasmic organelles and large clear spaces. It is a severe condition often seen with viral hepatitis or steatohepatitis. It is distinct from fibrotic changes, in which depositions of collagen fibers are seen on histology. Ascites is a collection of fluid in the peritoneal cavity, rather than a histological feature. Which of the following is not a response normally seen in liver disease? A. Necrosis. B. Inflammation. C. Intracellular accumulation. D. All of these are commonly seen in liver disease. The answer is D. All of these are commonly seen in liver disease. The liver generally responds to injury in the following ways: inflammation, necrosis or apoptosis, degeneration leading to accumulation of intracellular deposits, fibrosis, and regeneration. Some of these, such as inflammation and mild degeneration, are reversible. Other changes, such as severe degeneration and fibrosis, may be permanent. You are assessing a patient complaining of 3 days of fever, crampy abdominal pain and profuse, watery, mucoid, non-bloody diarrhea. The patient recently completed a course of clindamycin after having her wisdom teeth removed. The patient has not eaten any raw foods, red meats, shellfish, seafood, or greasy foods recently, and has not had any recent travel. What is the most likely cause of her diarrhea? A. Clostridium difficile. B. Cryptosporidium parvum. C. Escherichia coli. D. Shigella dysenteriae. E. Salmonella typhi. The answer is A. Clostridium difficile. The most likely cause of this patient's diarrhea is Clostridium difficile, also known as C. diff. Clostridium difficile typically causes watery, non-bloody, mucoid diarrhea, associated with fever and abdominal pain, most commonly in patients who have completed a recent course of antibiotics. In the past, it was thought that clindamycin was the most frequent antibiotic-related cause of C. difficile, but recent studies have shown that other classes of antibiotics, including cephalosporins, are associated with comparable rates of C. difficile diarrhea. In this patient, the characteristics of her diarrhea, associated symptoms, and recent antibiotic exposure are most consistent with C. difficile as the cause of her diarrhea. Escherichia coli exists in multiple subtypes, but often is associated with bloody diarrhea after eating undercooked red meats, ecdiarrhea, or watery diarrhea after traveling to a foreign, undeveloped country, ETEC diarrhea. This patient's history is not consistent with E. coli infection. Salmonella and Shigella diarrhea are each typically bloody. This patient's diarrhea is non-bloody. Cryptosporidium parvum diarrhea is often watery, as is the case in this patient, but it frequently occurs in immunosuppressed patients, is typically not mucoid, and does not have a known temporal association with taking antibiotics, as does C. difficile. You are the nurse taking care of a patient who is receiving ibuprofen for back pain, and the patient complains of burning epigastric pain after swallowing his ibuprofen pills for the last few days. You suggest which of the following to the patient? A. Try taking the pills without any water. B. Try taking the pills with a full glass of water. C. Take the pills right before lie down you go to sleep. D. Request the pills more frequently. E. Try taking the pills while lying down. The answer is B. Try taking the pills with a full glass of water. Bilesophagitis is an irritation of the esophagus that can occur after a patient takes certain medications orally. Bilesophagitis is caused both in part by local, direct damage to the esophageal mucosal lining from the pill itself, as well as from, depending on the particular drug, the systemic actions of the drug. In this patient's case, he takes ibuprofen, which can both damage the esophagus lining directly, and also predispose to poor mucosal repair from its systemic effects. There are a number of interventions to remediate piloesophagitis. If the medication can be changed to an equivalent drug that has less of a known propensity to cause piloesophagitis, that is a valid option. In addition, as in this case, you can encourage the patient to take the pill with a full glass of water, as this helps increase the odds of the pill traveling the full distance of the esophagus to the stomach, and not getting caught in the esophagus, causing localized damage and esophagitis symptoms. Taking the pills while lying down would be an inappropriate intervention, as this increases the risk of the pill getting stuck in the esophagus, causing localized esophagitis symptoms. The same reasoning applies for taking the pill right before lying down for bed. Taking the pills without any water would also decrease the odds of the pill fully traveling down the esophagus to the stomach, and therefore increases the odds of experiencing piloesophagitis symptoms. Requesting more of the pills without addressing how the patient is taking the pills would be inappropriate, as they appear to be inciting the esophagitis pain. You are the nurse taking care of a patient with dull epigastric abdominal pain that is new since returning from vacation 3 weeks ago. He was recently on vacation to India where he did not have any dietary restrictions. Fecal occult blood testing stool cards revealed occult blood in the patient's stool. He does not have any associated diarrhea, weight loss, hematemesis, or other symptoms. Which of the following is the most likely cause of the patient's abdominal pain? A. Pancreatic cancer. B. Traveler's diarrhea. C. Peptic ulcer disease. D. Malnutrition. E. Aortic dissection. The answer is C. Peptic ulcer disease. The patient's symptoms in studies: dull epigastric abdominal pain, FOBT occult positivity, as well as the time course relative to his vacation to a developing nation, 3 weeks removed from travel to India, are each quite consistent with peptic ulcer disease. Peptic ulcer disease is rather rare in developed countries, as the causative organism, Helicobacter pylori, has essentially been eradicated in developed countries. However, in developing countries, such as Mexico or India, which are frequently traveled places by Americans, patients can be exposed to H. pylori in the food and water supply there, which can then begin to grow in the patient's gastrointestinal tract. As a result, it can predispose the patient to peptic ulcer formation, which would present, as in this patient, with a dull epigastric abdominal pain, discomfort as well as dried or occult blood in the stool. The patient does not have any diarrhea or lower abdominal pain that would suggest traveler's diarrhea. There is no evidence that the patient is malnourished from the information provided. While vague, dull, gnawing abdominal pain is a potential sign of pancreatic cancer, peptic ulcer disease is a more likely etiology of this patient's abdominal pain given its time course relative to his travel to India. There is no evidence to suggest that this patient is experiencing an aortic dissection, as that is often described as tearing back pain. You are the nurse taking care of a 22-year-old female who complains of increased frequency of loose non-bloody, non-mucoid stools for 3 days. She notes that her eating habits have not changed recently, she has not traveled outside of the United States recently, she has no known sick contacts, no family history of colon cancer, and does not take any medications on a daily basis. She notes that her job has become increasingly stressful over the last 5 days, and that in the past, when her job or relationships have become stressful, this has triggered abdominal cramps, and diarrhea that is temporarily relieved with bowel movements. She currently is a febrile, with a normal white blood cell count, and vital signs within normal limits. Which of the following is the most likely diagnosis? A. Irritable bowel syndrome, IBS. B. Gluten intolerance. C. Colon cancer. D. Ulcerative colitis. E. Aortic dissection. Lactose intolerance. The answer is A. Irritable bowel syndrome, IBS. IBS is a gastrointestinal condition characterized by abdominal pain or cramps, as well as acute episodes of diarrhea and/or constipation that is often triggered by psychological stressors such as depression or anxiety, or a preceding gastrointestinal infection. IBS is more common in young females than other demographics, and often can be comorbid with clinical depression or anxiety disorders. Its pathophysiology has not yet been fully characterized. There is no definitive diagnostic test to confirm a diagnosis of IBS, but the lack of blood or mucus in the stool, as well as the lack of a fever or elevated white blood cell count, all are consistent with a diagnosis of IBS. Further, in this patient, given that she is a young female whose symptoms for this episode and prior episodes coincided with psychological stressors and resolved with bowel movements in resolution of her stressors, and who also had no fever, elevated white blood cell count, vital sign abnormalities, or concerning historical details, foreign travel, dietary changes, sick contacts, IBS is the most likely diagnosis. Ulcerative colitis would be more likely to present with recurrent episodes of bloody and/or mucoid diarrhea, as opposed to non-bloody, non-mucoid diarrhea. Further, given this patient's relationship of symptoms to immediate psychological stressors, her symptoms are more consistent with IBS than ulcerative colitis. Colon cancer would be an unlikely diagnosis in a young, otherwise healthy patient with no family history of colon cancer. The fact that she is experiencing non-bloody, non-mucoid diarrhea does not in and of itself provide evidence for colon cancer. Colon cancer may present with occult blood in the stool, melanotic stools, or blood-streaked stools, but would be highly unlikely in a healthy young patient. Gluten intolerance and lactose intolerance are reasonable thoughts when evaluating a young, otherwise healthy patient with non-bloody, non-mucoid diarrhea. Lactose intolerance would likely present at a younger age though, and the patient's diet reportedly has not changed prior to her diarrhea episodes, which would argue against a dietary etiology of her diarrhea. Further, given the close relationship of her symptoms to acute psychological stressors, IBS is the most fitting diagnosis. You are the nurse taking care of a patient who underwent a total abdominal hysterectomy 36 hours ago. The patient states that they have not passed flatus or had a bowel movement since the surgery. You reassure the patient that this is common following surgery, for which of the following reasons? A. Postoperative amphetamines. B. Postoperative ILS. C. Viral infection. D. Fungal infection. E. Bacterial infection. The answer is B. Postoperative ILS. In the presented scenario, the patient is just 36 hours removed from a total abdominal hysterectomy, which is an invasive abdominal surgery. During a hysterectomy, the patient typically receives inhaled anesthesia, as well as opioid pain medications, which each individually can result in a postoperative ILS. Furthermore, given that there is manipulation of abdominal organs in accessing the uterus, simple mechanical manipulation of the bowels during surgery can be enough to result in a postoperative ILS. For each of these reasons, postoperative ILS is a common occurrence, and is the most likely cause of this patient's lack of passing of flatus or feces. There is no reason to think that this patient received postoperative amphetamines. Furthermore, if the patient did receive amphetamines, that would likely stimulate the digestive tract, rather than inhibit its activity. Neither bacterial, viral, nor fungal infections would be likely causes of lack of flatus or feces passage following a surgery. These infections would be more likely to cause loose stools, diarrhea, rather than an ILS. You are the nurse taking care of a 2-week-old firstborn male child. His parents brought him to the emergency department because he has been projectile vomiting for the last 5 days. On physical exam, you note a palpable olive within the upper abdomen, and lab work shows a hypochloremic metabolic alkalosis. Which of the following is the most likely diagnosis? A. Toxic megacolon. B. Pyloric stenosis. C. Type 2 diabetes mellitus. D. Achalasia. E. Esophageal tumor. The answer is B. Pyloric stenosis. This is a congenital condition that most commonly affects firstborn male infants. Pyloric stenosis is a congenital narrowing and excessive tightness of the pyloric sphincter, resulting in difficulty passing food from the stomach to the duodenum in the infant. As a result, the child frequently forcefully vomits until a surgical intervention reduces the tone of the pyloric sphincter. On physical exam, a palpable olive can sometimes be felt within the upper abdomen, representing the pyloric sphincter. On lab work, due to the potassium and chloride lost in the vomited material, a hypochloremic metabolic alkalosis can be observed. On occasion, there is a history of the mother having taken erythromycin antibiotics during gestation. Esophageal tumor is highly unlikely in a newborn, as both of the most common types of esophageal tumors typically occur in patients 50 and older. Achalasia would present as difficulty swallowing, rather than as frequent vomiting of stomach contents. In achalasia, the food cannot pass beyond the esophagus, whereas in pyloric stenosis it cannot pass beyond the stomach. A palpable olive would not be felt in achalasia. Type 2 diabetes is extremely unlikely in an infant, and would not likely present with gastroparesis as its first symptom.